Dear friends, after listening to all these core areas in these medical legal cases, if you are wondering what is the real problem and what is the real solution, I have both of those with me. The real problem of all these medical legal cases, if you go into them and analyze them in detail, is, as Dr. Nirmal nicely said, a casual loose talk of a colleague of yours. That is, in fact, the inciter or the point which makes a medical legal case. It is not your result. It is not that no PL vision. In fact, we have patients who are with no PL happy with us. We have had cases where we have bungled up, or rather by intent or by accident, and yet those patients have been faithful to us, even come to us for the other eye. But these patients, when they have a casual remark by a neighboring ophthalmologist who might have good relations with you, or rather he wouldn't even have done it with real intent of harming you, just a casual remark from him is the core point around which all these medical legal cases are built up. And if you want the solution, the only solution for all these problems is the records which you can produce to the court of law or to the Consumer Commission. It is just the records. You might explain it in your own version. The patient will have his own version. The defense, the prosecuting lawyers whom they hire will have their own version. The court also will have their own version of the redoing of all these events and then label that event as a negligence and thus offer compensation. But if at all anything can defend you in this area, in this time of distress, it is a medical records. So for the next 10 minutes, we'll go into depth into these medical records and see what are the small things which we are erring upon and how much we can correct them so that we can get good about it. Previously, if you understood, medical records have been voluminous and voluminous. Most of the times, you will understand the usual mistake will happen like this, sir. You would have done a case, you will have everything on it, the consent, the theatre notes, everything will be in the case sheet. Patient will have a bad eventuality. Suddenly, they'll out of turn come inside your consulting room for a review. At that time, you will not have time to trace the case sheet because they will not be in appointment. So you will just give them some treatment. You will not make it entered in the case sheet. That is a big usual problem which happens. Please understand that more so in these cases which went wrong this way or that way, every review should be recorded. Now, probably my previous speakers stressed to you about the consent and the theatre notes and others, but I strongly believe even the reviews are important. Every reviews, make them detailed, tell everything and say what you did for it. This becomes a good defense. Certain times this happens. What happens is you will see these patients usually out of turn. They'll ring up and come at odd times inside your clinic, complaining about whatever is there, like red eye, watering, pain and something. And every time you don't want them in your consultation room. In fact, that is the truth. You don't want them in the consultation room. You want them to be the shortest, door to door. You want the shortest possible time. So most of the times you don't even want the case sheet to be traced. You bring them inside your room, give them some treatment, send them, but there is no record. So please understand, all medical records which we have to maintain, the MCI says should be maintained for 3 years. 3 years you have to maintain records, and anytime if it is asked for, you should be able to submit it within 72 hours. This is the most important point about medical records. All other things mostly we are doing not properly, but only thing, this maintenance and safeguarding of these case sheets and every time recording whatever happens in the patient relationship inside these case sheets becomes important. Second is, even not the written word. Most of times it is a spoken word which is a mistake. Certain areas which I think surely you will also reciprocate with my feelings. Most of the times it is what the patient, what our sisters speak to the patient outside, what the telephone person tells when the patient seeks an appointment to you. All these also matters more than what you speak to the patient. You are most of the times courteous to the patient, but it's not necessary that the other person around in your institution behave in the same way. So most of the times we have to instruct these people that these patients, they have to attend very importantly. In fact, I have a habit of writing VIP in my case sheets. VIP, usually every patient becomes very happy when they notice that VIP mark, but for me it is very irritating patient. I mention VIP when I say very irritating patient, and most of the times my paramedics understand this and they start handling the patient very courteously. It works somehow. Third most important thing is legibility of records and who can make entries into records. You cannot have everybody, Tom, Dick and Harry, entering into the records. There is certain clear-cut rules. Only very authorized personnel can have an entry. They can write an entry, like a sister. She should be a qualified sister, a qualified theatre sister or a ward sister, and yourself. Only, and your assistant, whoever is. These people can only enter. And if at all they enter, they have to clearly make an entry of the date. They have to sign, and if possible, also put a seal, a rubber stamp of their name. And the treatment advised, whatever, should be written very carefully. Very carefully. In fact, restricted physical activity, if that is the only advice you are going to give to the patient, please register it very, very legibly. Don't think that only the medicines which you give are important. Even all the words which you say to the patient is important. Only authorized persons can make entries into the case sheets. If the case sheets show that entries have been made by other people, it will make it appear as if you have doctored the case sheet, or the case sheet is not properly maintained, or there is no decorum in maintaining the case sheets. Preservation and safety we have discussed. Today we are moving towards EMRs. EMRs are more sophisticated. They are also more handy and more comfortable. For the money, they can do this business far better than the written case sheets. But somehow from time immemorial, we have, from our student days, we have a strong affection for the written case sheets. So if you are going to maintain written case sheets or EMRs, the rules are the same. Nothing changes. Your MRD, please keep it the most safest place in your clinic, like your cash box. Don't relegate it to next to the toilet room. Usually it will be the next to the restroom where we have less patient flow. We keep that as a MRD room. Please keep it very safely and have some clear-cut registers in the MRD, like whoever enters should record their name, take case sheets, and then replace that case sheet, so that you have a record of who enters, who picks the case sheet and brings to you, and then after the patient is seen, who goes and re-keeps those things into the proper areas. Informed consent, much has been spoken about it. I didn't even discuss this point. We all understand that informed consent is very important. Only thing that I think is being overlooked is, most of the times in this, you won't enter that GVP. If you want guarded visual prognosis to be clearly understood by the patient, you would have written it into your case notes. You would have written it into your case notes. You would have written cataract surgery, phaco IOL under GVP. These things we write. I have a colleague of mine who writes phaco IOL under zero visual prognosis. That also we write. But this in the consent form also, if you can make that entry, that becomes very important, because the patient in his local vernacular should have been explained to this point and should sign and vouch that he has been explained to this point. Tomorrow you cannot you say that, because most of these the 50-50 cases, we do surgery and we end up having a good vision. We think it is a very good vision, but the patient thinks it's a very poor vision. This is the conflict. In that situation, you will keep saying, I told you, ma, before surgery itself, I told you your eye will come only improve to this level. This is what we keep saying. And every time the patient keeps saying, no, I had very good vision before surgery, now only I am having less vision. This is the conflict which we usually face. So to end up not facing this, please, this guarded visual prognosis point, make a clear-cut entry, or rather you write it. You personally write it and see to that it is added in the consent form before it is signed. OT notes, another important area. The time of surgery, what anesthesia was used, whether there was a standby anesthetist, whose sister assisted you. All these become important. And more so if there had been a PC touch, if there had been something which is untoward during surgery, please mention them. Don't try to, usually we have a habit of trying to avoid them into documentation. I sincerely believe it can be written. It can be written in the case sheets and explained that you overcome these complications, which are all accepted complications in the eventuality of surgery. Nobody says always surgery is safe. All they say is, if at all you encounter a complication, whether you have a training and resilience to overcome that complication, a good outcome to be given to the patient is the important story. So any complication, if it occurs, you should write it into the OT notes. The sticker, the IOL sticker, should be properly placed. Even the consumables which are used, you can make a mention of it. If you have used viscoat, you can make a mention of the viscoat. All these things become important. In case you have a bad surgery, then usually schedule the reviews as very commonly as possible. That is the point which I follow. I sincerely think you will also reciprocate the same. The patient wants to come and see you frequently if he has a complaint. Don't avoid them. See them. And it's also a good habit to ask them to come in the odd times of the consulting hours, as you tend to end your consultation or you begin your consultation. Or I have a friend of mine who will always ask these patients to come on holidays and Sundays to make the patient think that even on Sunday doctor is open and seeing us, taking care of us. This kind of psychology you should work on the patient. You should work on the psychology of the patient and make him understand that you are spending that extra effort, you are making that extra effort to give him some comfort in the presence of a complication. I am sure if you can work on the psychology, most of the times patient will accept complications. The next most important document which any lawyer relishes is a discharge summary. One full stop or comma which is misplaced in a discharge summary, the lawyer will tend to create a full consumer protection case around it. Any small word which is wrong. I'll tell you one example where there had been written immature cataract in the case record, and in the discharge summary somebody has typed grade 2 nuclear sclerosis with PCC. The lawyer person is asking me, sir, they have made a mistake. They have misdiagnosed the cataract. This is what he was trying to tell me. They have misdiagnosed the cataract. Just because the wordings which was made to write about the cataract was different, that fellow is thinking that the whole diagnosis is wrong, so the treatment is wrong. Now he is eligible for a Consumer Protection Act. This is how things are going. So please understand that even the vision which you put in the case record and the vision, the pre-op vision, usually you make an entry. Usually you make entry of the diagnosis, the vision, the fundus finding, A scan value, and the theatre, or rather the surgical. These are the discharge summary findings, discharge summary points. Please don't make a mistake between the case records and the discharge summary findings of the same points. Please understand that these same points should be verbatim the same, verbatim. Audit meetings inside the hospital are usually thought should be done in medical colleges. They usually think that audit meetings are for medical colleges, big places, lot of consultants, they sit and chat, take 2 biscuits and coffee and end up fighting amongst themselves. That is how the opinion of audit meetings is. But I sincerely believe even a small single person practice, you should sit with your A-scan person, sit with who does theatre assisting for you and evaluate your results. Even a small error in a result where you get 0.75, 1 in a properly done IOL, you can discuss all these things. So at least make a habit of keeping one coffee meeting with your staff and record it as an audit meeting. You have a record of your internal audit. This is an internal audit where you yourself are taking sincere care to audit your own proceedings. Please do that. Everything you write, like you might send a person to a retina specialist, you might send the person for anesthetic fitness, you might send it to a physician. Don't write or scribble in your letter pad and give it to the patient open. Please use an envelope and seal these envelopes and give. This creates more decorum into these communications, which are privileged communications. And this, in fact, works on the patient's psychology. He thinks that he's going to see an important doctor who's going to give him a bit more relief than what you can give, and then he's going to come back to you and keep continuing on that. So please give them as privileged communications. And usually a legal notice, if it comes to you, it comes in an ordinary post. Don't think it will come in a big registered post. So all posts which you receive, please have some way, some channel or some methodology in your center which treats all these mails properly and respond to these mails properly. If you have a website address, if you have an email address which is given in your letter pad, then patients might communicate with it. Today is a period of social media, so they might communicate. So please respond to these. You have some system in your hospital where you respond to these properly. Appointments and schedules I discussed. Anytime these patients who have some eventuality in a surgery which is just gone otherwise wrong will usually want more appointments and more schedules, have some way, work out some way to have it more in your system. Payments and reports. All these reports, whatever the report, you would have had a primary test where the blood sugar would have been very high. Then you would have done a repeat test where the blood sugar has come down. Now your record will have only the original 353 blood sugar. It will not have the next 180 milligrams % blood sugar. That becomes a mistake. So please understand that every medical record which the patient has, or rather the investigation report, should be put into the case sheet. If not the Xerox copy, the original of the case sheet should be added to the case sheet. And these case sheets, the more they thicker they become, understand, more safer you are. Because people to find fault in it becomes less. Any legal notice, if it comes to you, don't panic, don't shiver, don't try to hide under something. Face it strongly, face it boldly. Today there is PPLSs which will help to face it. You can have medical indemnity insurance, you can have lawyer friends, you can have any number of people. You have Dr. Deshpande, you have Dr. Nirmal Frederick, you can take their help. All these people can help face these legal notices. And the reply to a legal notice, take it from me, should not have any detail other than what is asked for. If they ask for A, only finish with A. Don't even volunteer B. Only keep it to the barest minimum. The whole art of replying to a legal notice is to write nothing but fill a page. That is the whole art of legal notice reply. So you just keep writing everything and just don't volunteer any information. Only exactly verbatim what is asked for, you just keep replying. If at all these medical records are proper and prim, then you have the most ultimate luxury in our clinical practice, as I see, is peace of mind. If you have that, then it's a fully successful practice. The feedback forms, which you can have a habit of collecting from the patients every time, at least from your surgical patients, please have a feedback form, which will prove that you have hundreds and millions, thousands of surgery before you, where patients have had a very good outcome, so that they cannot claim that you have been a very loose and very irresponsible doctor. That is what they'll try to prove. They'll want to prove. Then this can be a defense against that being proved. Ladies and gentlemen, it's been a pleasure being associated with Dr. Deshpande, Dr. Nirmal Frederick, and this, I think, should have some messages at least for take home. Now we open the session for discussion. We can have a discussion forum for next.